meet you all. Thank you, Carly and Willis, for inviting me to do this lecture today on our first lecture of the year. It's going to be on addiction medicine and the medications we use for opioid use disorder, and specifically the different protocols that we have at Kings County. So, as we're all aware, there is an opioid crisis in this country. From 1999 to 2017, there were nearly 400,000 overdose deaths involving opioids in the US, and a national public health emergency was declared in 2017. In 2018, 10.3 million people misused opioids, and 2 million had an opioid use disorder. With about 130 people dying each day of an opioid-related overdose, this epidemic has generated significant government funding for the prevention, treatment, and recovery of Americans, and has shaped the priorities of our local communities. As you can see here, the numbers are increasing and not slowing down at all, and we are having a seemingly exponential, huge crisis unfolding in front of us. This is a map from 2016 showing the color coding the states with the most drug overdose deaths per 100,000 people, with the darker colors having more drug overdoses than the lighter ones. Here's a very telling photo showing how tiny the 2 milligram amount of fentanyl that's required for a lethal dose for most people. And so that can really be laced into really anything in the community and can cause a lethal overdose that can present to the emergency room. This graph is to show how substance use disorders have crossover with mental illness, but it's not exclusively. And this Venn diagram does show that. So in 2017, there were around 20 million people with substance use disorder, 8 million of them having also been diagnosed with a mental illness disorder. The term opioid referred to opiates, derived compounds, and natural and synthetic analogs. And so you can see here all the different types of opioids that we are familiar with. And this table also kind of categorizes them, where you can see the naturally produced opiates, morphine, codeine, and heroin. You have your semi-synthetic opioids, and then you have your fully synthetic fentanyl and methadone. Humans have at least 3 different types. Excuse me. So, humans have at least 3 types of opioid receptors located in the central nervous system, peripheral nerves, gut, and the immune cells. Most of the clinically significant ones, as we know, are attributed to the activity at the mu receptor. The brain regions most densely concentrated with opioid receptors are associated with pain perception, reward pathways, and respiratory function. We are all kind of familiar with the physiologic effects of opioids. So the activation in the CNS causes analgesia, sedation, euphoria, pupil constriction, decreased respiration and heart rate, and nausea. And activation in the gut decreases motility, so causes constipation. And then also in the periphery, you have analgesia and modulates inflammatory responses. So opioid use disorder, or OUD, is a complex illness characterized by compulsive and chronic use of opioid drugs, even when the person wants to stop, and that causes clinically significant distress or impairment. With repeated exposure to opioids, tolerance or needing more to produce the same effect develops, and tolerance develops at different rates and to different degrees for different symptoms. So little or no tolerance is kind of developed for constipation and pupil constriction, but you will get rapid tolerance for most of the other symptoms. All opioids produce similar withdrawal symptoms when stopped abruptly, and the severity varies with the amount and duration of use. So with longer acting opioids, symptoms usually being later and last longer. And so these are important for us to understand when you have a patient and you're asking when their last use was. So short-acting opioids, withdrawal can be within 6 to 12 hours, peak at day 2, 3, and can even last for about 5 days, whereas methadone, you can start to onset at around day 2, the beginning of day 2 or 3, with symptoms at around 4, and they can last up to 3 weeks. But this is obviously a large variation. You can have people getting mild symptoms of methadone withdrawal within a day. Because of the significant and oppressive cravings and withdrawal syndrome associated with opioids, the medical world has developed a few medications for opioid use disorder, which in conjunction with addressing social barriers to recovery and counseling support are meant to help sustain recovery in patients with OUD. The 3 medications approved by the FDA are methadone, buprenorphine, and naltrexone. And here are some of the mechanisms as well as some of the typical doses that I will go into. So here's a timeline of medications for OUD. So in 47, methadone was FDA approved for analgesia. In 1970, it was approved for withdrawal, and in 73, approved for the maintenance therapy of OUD. And in 74, opioid treatment programs, or OTPs, were able to dispense methadone for maintenance. In 84, oral naltrexone is approved. 2002, buprenorphine is approved. And in 2010, the extended release injectable naltrexone is approved. So previously, OTPs had to dispense, so in 74, yeah, we had our OTPs. In 2000 is when the X waiver is introduced through the Drug Addiction Treatment Act of 2000. So the X waiver is basically legislation that authorized the outpatient use of Schedule III drugs, including buprenorphine, which was then approved in 2002. In 2013, OTPs are able to dispense buprenorphine in the same manner as office-based practitioners, because previously OTPs had to dispense buprenorphine at the program as they did for methadone with restricted take-home doses. And then finally, in January this year, the Substance Abuse and Mental Health Services Administration and the DEA formally announced the elimination of the X waiver. So now any clinician with a current DEA registration that includes Schedule III authority can prescribe buprenorphine for opioid use disorder. So the first medication to be approved is methadone, and here's 2 of the formulations, the tablet and the IV version or IM version. Methadone is a synthetic opioid discovered in 37, approved in 47. Its oral bioavailability has a wide range between 36 and 100%. And it has been taught that patients who benefit from methadone are ones who prefer agonist therapy, prefer the structure of observed dosing and their services in one location, having co-occurring pain that has not responded adequately to other treatments and are unable to be abstinent of opioids on partial agonist therapy. Methadone, while an effective treatment, can have sedating effects on patients, has the potential for overdose, as we're all very aware, and places social and time-consuming burdens on the patients, as it must be administered in a federally regulated OTP, which has strict regulations and is often only located in low-income areas. Later, I'll go more into the detail of the controversies and complexities of methadone, but now I'll just kind of go over the pharmacology. So as I said, it's a full agonist at the mu receptor, long-acting, longer, a half-life of about 15 to 60 hours, and it has the potential for significant respiratory suppression and potential arrest in overdose when it's not used as prescribed. And as for QT prolongation, there was one paper that states that a dose of 75 milligrams of methadone, the average QT prolongation was 9 milliseconds with a standard deviation of 39. A key component to remember is that it has a weak affinity for the mu receptor. So any partial agonist or full antagonist with a stronger affinity for the receptor will displace methadone and cause precipitated withdrawal. And so that's the really horrible side effects that we probably have all seen when you have the receptor at a full agonist, which then drops down to either partial or to the antagonist level, and then you have all the symptoms of withdrawal happening in front of you. So the second medication for opioid use disorder, which it's also approved for alcohol use disorder, is naltrexone. 2 of the formulations are seen here. You have the oral tablets and the extended release injectable suspension called Vivitrol. Naltrexone is a long-acting, high-affinity competitive receptor antagonist. And in sufficient plasma concentrations, naltrexone fully blocks the opioid effects, reduces and suppresses opioid cravings, and it blocks the euphoric and sedative effects of opioids. So a person may experience reduction in cravings, though not as significant as you'll see with buprenorphine or methadone. And people taking naltrexone develop more sensitive opioid receptors because they're not exposed to an agonist. And so this means individuals can have a higher risk of overdose if they stop naltrexone and start using opioids in their previously familiar amounts. The tablet is approved for the blockade of exogenously administered opioids, typically started 7 to 10 days after a period of no opioid use, can be taken as a 50 milligram dose, but it's associated with poor adherence. So because of that, there's Vivitrol, which is that monthly injection of 380 milligrams, and it's recommended for the prevention of relapse in patients who are opioid free. It's important to understand that naltrexone is not naloxone. Naloxone is a drug that can temporarily reverse the effects of an opioid overdose. Anyone can give this very fast-acting medication as a shot or spray, nasal spray, and the use of naloxone could be its own lecture, which I won't go into today. But naltrexone is not an emergency drug. It's prescribed as part of a treatment plan to help to stop using a drug or consuming alcohol. And then just wanted to highlight the difference between these two because they are similarly named, but they have very different medical uses. And then finally, buprenorphine. So this is the third drug approved for management of OUD. It's a semi-synthetic analog of thebaine. Thebaine is a constituent of opium and is chemically similar to both morphine and codeine, but it has stimulatory effects rather than depressant effects, just fun facts. Buprenorphine, or as we affectionately call it, bup, was approved in 2002, is a Schedule III drug. And here are some of the different formulations. So we have Suboxone on the left, which is the sublingual film, which we're familiar with, Belbuca, which are the buccal films, which we are using in our microinduction pathway and have microgram dosages as opposed to milligram. And then here we have Sublocade, which is a monthly 300 milligram subcutaneous injection that actually goes into the abdomen when it's administered. So buprenorphine is a partial agonist. It has very high affinity for and slow dissociation from the mu receptor, which leads to the prevention of withdrawal symptoms, a decrease in cravings, and a decrease in the effects of other opioids. As a partial agonist, buprenorphine has a ceiling effect, which means that there's a plateau to the opioid agonist effects at higher doses, which will result in less sedation, both cognitively and psychomotor, than methadone and morphine, while still decreasing cravings. So it has a comparatively minimal amount of respiratory suppression and no respiratory arrest when used as prescribed. And the partial agonist prevents withdrawal, maintains a steady level of opioid activity like methadone, but like naltrexone also blocks the effects of the other opioids. So because of these advantages, it is now the first line medication for OUD this year. One of the most important features of buprenorphine to understand is its ability to displace other opioids. So like we talked about, can precipitate withdrawal, except when administered in those micro or very low doses as used in our Belbuca formulation. Because of extensive first-pass metabolism and a less active metabolite called norbuprenorphine, it has a poor oral bioavailability when swallowed of less than 5%. So that's why it needs to be sublingual, buccal, or IV. And that all kind of bypasses that first-pass metabolism. It's generally less stigmatized as a treatment for people with OUD compared to methadone. It's an office-based treatment available for general and PCPs to prescribe and administer. And office-based treatment programs only work for patients with access to primary care or a chemical dependency clinic, something that is historically a little less accessible to many low-income or uninsured people of color. And when X waivers were a thing, incentives to obtain a buprenorphine waiver were often lacking for providers serving the publicly insured or uninsured due to limited reimbursement rates and lack of time and resources to pursue the training, which we specifically saw here at Kings County not 5-10 years ago. We're at an exciting inflection point in the history of management of OUD because we're no longer restricted by the X waiver, which has broken down the clinician's barrier to acquire experience and mentorship to properly administer and care for patients taking buprenorphine. Again, it's important to understand how buprenorphine interacts with other opioids, especially when managing OUD in the ER and the OBS unit. So if you give buprenorphine, it occupies the receptors. If you give an agonist followed by buprenorphine, it will displace the agonist and can cause precipitated withdrawal. If you give buprenorphine followed by an agonist, the buprenorphine will stay on the receptors and the effect of the agonist is decreased. And then if you were to give buprenorphine followed by an antagonist, it will stay on the receptors, but the effects of the antagonist has slower onset, but will precipitate withdrawal eventually. But these are just kind of generalizations. And now for my wonderful opioid receptor graphic demonstrations. It took like a whole 10 minutes. So why is Suboxone formulated as buprenorphine with naloxone? This is because naloxone has minimal bioavailability when administered sublingual or buccal. So the Suboxone combination formulation was developed to decrease diversion to IV misuse. Okay, so now that we've gone over the pharmacology of the medications, I'd like to pivot to another very important topic that helps frame the opioid crisis specifically in our community. And yes, I will take any lecture opportunity to describe things from a social justice lens. Attention to the opioid epidemic has primarily focused on white suburban and rural communities. Less attention has focused on Black communities, which are similarly experiencing dramatic increases in opioid misuse and overdose deaths. And as you can see from this graph from the CDC, there was a huge increase in overdose death rates for the non-Hispanic Black population from synthetic opioids other than methadone, like fentanyl and fentanyl analogs between the years 2014 and 17. This was the highest in this population compared to all other races and ethnicities. The social determinants of health and other community and system level factors cannot be ignored when discussing the contextual factors associated with any major public health issue. Only 10% of people with a substance use disorder in the general population seek treatment, and this is magnified in the Black community where there is significant historical mistrust of the healthcare, social services, and justice systems. So now I'll provide some historical context that may help us understand how we have gotten to this disparity. So 5 decades ago, when opioids and crack cocaine were devastating Black communities, the national response under the Nixon administration was the war on drugs. These stricter drug policies for possession of sale of drugs, known as the Rockefeller laws in New York specifically, were put into place and resulted in widespread incarceration and severe sentencing for low-level, nonviolent drug offenses, leading to the disruption of primarily Black families and communities. This population was criminalized for drug-related offenses at much higher rates than white Americans, and this has had lasting effects throughout the present day. In 2017, though the Black population represents 12% of the US adult population, they made up a third of the sentenced prison population. At the same time, also under Nixon, the FDA approved methadone for the treatment of OUD. Previously, it was just for chronic pain. And with this came stringent regulations that continue to influence how methadone clinics shape the places and identities of the patients they serve. In the 70s, debates about the nature of addiction, which some groups understood as a chronic disease and others as a moral failing with abstinence as the only solution, were reflected in the physical spaces that provided methadone. The new regulations assumed people taking methadone were criminals, the types of people who substituted one drug for another and would illegally sell their methadone on the streets to make a profit. People taking methadone weren't quite considered patients, so a traditional clinic would not suffice. As I discussed before, the FDA mandated patients on methadone report to designated distribution sites or OTPs almost daily to receive their medications. Patients were required to line up publicly outside of the OTP, stick out their tongue while being watched to ensure their methadone was swallowed. Patients had to undergo punitive weekly urine screenings, and if they were positive for other substances, they'd be kicked out of the program and required counseling services. Many of these requirements, with slight variations depending on the state, persist today. Thus, methadone, stigmatized in many Black communities, and as some people know, just one drug for another, is often viewed as the default treatment for Black communities and often the only treatment option. This disparity in access to buprenorphine by race, geography, income, and insurance status may be related to both the patient and clinician. So here's just some photos of different clinics through history. So here's one in Central Brooklyn in 1990. Here's one in Eastern Brooklyn in 97. And here is one in 2020 in Harlem. Still unmarked, kept secret, out of sight, out of mind kind of vibes. In May of 2020, the Substance Abuse and Mental Health Services Administration released a report titled "The Opioid Crisis and the Black and African American Population, an Urgent Issue," which is a detailed report about the state of the opioid crisis as it relates to the Black American population, setting it within the context of the mass incarceration due to the war on drugs, the exacerbated mistrust of the medical system because of this history, and the report offers examples and paths to support the Black population living with addiction. The report describes how Black Americans with substance use disorders are doubly stigmatized by their minority status and their substance use. Negative images of Black Americans with substance use contribute to mistreatment, discrimination, and harsh punishment instead of treatment and recovery services. Mostly absent from these narratives are opportunities for compassion, understanding, treatment, and recovery. While it can be challenging to take a holistic view of an individual and see more than the substance use disorder, this may be even more so for the Black Americans who are subjected to the implicit biases of the healthcare system. Failing to bridge a racial cultural divide often contributes to premature termination of treatment among people of color. Engaging in treatments is a difficult task for all populations. When the cultural context is ignored or misunderstood, respect for the patient is lacking, and a lack of Black practitioners who treat OUD exists, it becomes very difficult for a Black American with OUD to engage with treatment. I put this image up from a news pamphlet called Black News from 1970 to illustrate the controversy surrounding methadone. From one side, as I described before, methadone can be academically viewed as a full agonist opioid, meant to maintain a steady state of opioid to decrease cravings and decrease the use of street drugs, right? However, another view can be illustrated by the following quote on the right side. Quote, "How about this sheer duplicity and cunning? First, the man floods our communities with his crystalline poison and enslaves our brothers and sisters to a living death. And then in a stroke of evil genius, he sees a better way to perpetuate his genocidal stranglehold on the addicted segment of our community through administering free high to the addict in the form of methadone. Walk by the building that occupies this corner between 10 and 4, and you will see 30 to 40 brothers and sisters just standing idly along the wall, looking for all the world like the zombies that they have become through the ingestion of methadone." So I bring this up not necessarily to open up an impassioned debate on the role of methadone as medication for OUD, but to inspire you all to be on frontline troops in the initiative to transition folks to the first line medication for OUD, which currently is buprenorphine for people who are interested. Research suggests that Black Americans with OUD have experienced limited access to the full range of medications for OUD when compared to whites. One study based in NYC found that the residential area with the highest proportion of Black and Latino low-income individuals also had the highest methadone treatment rate, while buprenorphine and naloxone were most accessible in residential areas with the greatest proportion of white high-income patients. A study from 2012 to 2015 found that those who self-pay or had private insurance represented nearly 74% of those who received buprenorphine during that time. Essentially, a two-tiered treatment system exists where buprenorphine is accessed by whites, high income and privately insured, while methadone is accessed by people of color, low income, and publicly insured. This is a map of the historically red-lined neighborhoods in New York City from 1938 with superimposed black dots showing the methadone clinics that are serving the communities in New York. If you look closely, you'll see the R Building Methadone Clinic here in East Flatbush. Moving on to the Kings County specifically and how we can manage opioid use disorder. So there's kind of 4 different things that we can do. Manage someone in overdose, manage someone with withdrawal. We have a macro induction pathway with buprenorphine or Suboxone, and then identifying patients eligible for the micro induction with buprenorphine through the Belbuca to Suboxone and potentially Sublocade pathway alongside full agonists in the observation unit. So this has been the initiative that Alec and I have been working on to kind of help to kind of standardize what we do and how we can help patients, which we've all seen, but for the interns, this is new. So number 1 is identifying and treating withdrawal with buprenorphine and methadone or our medications for OUD. Ordering an inpatient consult to the ED leads and catch team, which you do right off the bat as soon as you identify someone with OUD, whether it's just that they have a history of it, they're in withdrawal or overdose. At the end of the visit, having them go home with a naloxone kit, at least offering it and putting it in your note that you've offered it if they declined or they already have one. And then at the end, an e-referral to specifically the chemical dependency clinic in order for the R building to follow up, call the patient, and ensure that they're coming into the R building. So the first step, as I said, is identifying withdrawal. Patients may come in saying they're in withdrawal, triage may identify it, or you elucidate it from the history. Once that's done, you can ask what opioids they use, their last use, and how often they use. The next thing you would do would be to calculate the COWS or clinical opiate withdrawal scale, and do not overestimate. Giving more points runs the risk of precipitating withdrawal. And so really understanding that some of them are subjective, but to really not overestimate because it can be very dangerous. Determining if there is mild withdrawal, which is in our case is COWS less than 10, or significant withdrawal or COWS greater than 10. If the COWS score is greater than 10, you can treat with a medication for OUD. If they're on methadone and they are happy on methadone and they want to do methadone, you can offer buprenorphine, but if they want the methadone, you can give their 20 initial dose, maxes out at 40 at Kings County, unless you can verify the patient's dose by calling their OTP. The other medication, bup, usually we're starting at 8, redosing every 20 minutes with, and this is with informed consent of the patient. Letting them understand what we're doing, what the medication will do, the potential side effects, and all of these things, because the informed consent is going to be the most important thing about this whole process. So they are just as on board as you are for this process. We're encouraging starting with 8 as opposed to 4, because we have seen low dose 2 or 4 more likely to precipitate withdrawal, especially in moderate withdrawal versus higher doses of buprenorphine. They help to bind buprenorphine to the receptors and bring patients to a more receptor saturated state. And then if they're less than 10, you can give adjunct therapies or offer microinduction. And so here are some of the adjunct therapies that I have listed. It's in the tip sheet on Clinical Monster for our OBS pathway right now. And so all the different kind of doses, indications, and so just like a tip sheet that you can look at to help patients who are in mild withdrawal who only need adjunct therapy, or in the OBS unit and require some adjunct therapy. Here's the COWS score. So they include elevated heart rate, sweating, restlessness, pupil size, boner, joint aches, runny nose or tearing, GI upset, tremors, yawning, anxiety, and piloerection or goosebumps or goose flesh skin, whatever you want to call it. I would say the 3 most specific would be dilated pupils, yawning, and those the goosebumps. I think those are kind of really obvious on exam, you can see. The key principle in the transition from methadone to buprenorphine is the idea of bridging. So the pharmacologic principle of bridging incorporates a slow induction of buprenorphine onto the opioid receptors, facilitating a gentle loading of the high binding affinity and long half-life of bup, without significant displacement of the full agonist opioid. As lower binding affinity opioid occupying the mu receptors is slowly displaced or metabolized, up titration of the newly introduced bup will steadily bind to the newly free mu receptors. So this slow titration helps create a smooth transition from full agonist to partial agonist activity, eliminating the potential for precipitated withdrawal. Because of bup's higher opioid receptor affinity, even if additional methadone is added, it is less likely to attach to mu receptors, which are occupied by butte. So eventually the butte molecule will occupy more and more than the full agonist and become saturated. Microdosing or very low dosing, also known as the Bernese method, was first described in a case report in 2016 and provided the pharmacologic hypothesis of this small amount of giving bupe to not precipitate withdrawal. Yes, Kyle.
I know that you're supposed to start even if they're going like heavy withdrawal, right? So this rapid micro reduction, very small dose for like hours less than that.
Exactly. So it's for people who, if you have significant withdrawal, you just do the normal macro induction giving Suboxone. But if someone is not in withdrawal or they're in very small withdrawal, or they had Narcan given, and an hour after Narcan, you can start to give this Belbuca, which I'll go over in the next slide. Yeah. So here's the protocol. So it's for people for right now, we're doing for people of doses of 70 or less. Above 70, it gets a little bit more difficult and you probably will require a longer amount of days for the induction. Whereas right now, this is our 3-day induction protocol. So day 1, you're giving those Belbuca microdoses, Q4 hours, along with an opioid agonist. So if they're in withdrawal, we've actually had a case where someone wasn't, and so we didn't have to give them methadone, and they still went home just like last week on Sublocade. So it really, you have to kind of monitor to assess to see if they're getting those symptoms to give that agonist, but most of the time they do require it. That's kind of the standard, is they do get an agonist, the 20 milligrams you can give, and give another 20 to help them out. If they end up getting 40, they get 40 milligrams the second day and 40 milligrams the third day. And all the juniors, you're not going to be in OBS, so you're not going to be, you'll get more familiar with this as you become a senior. But for our seniors, this is the protocol that we're all working on. Day 2 is you increase that Belbuca to Q4 hours, it's 450. Day 3, you start the Suboxone, 2 milligrams Q4. And just continue the Belbuca, and they do get that 1 dose of methadone. But like I said, they're not going to be feeling the effects. I also had another patient in OBS who we gave, he was on day 3, we gave 2 milligrams. He was interested in kind of going. We went right up to 8 milligrams. He tolerated well. After an hour, we gave the Sublocade, and then he went home. So there's lots of variations, and you can work with the Catch team and talk with, me and Alec, or if you have questions, especially on weekends. But weekdays, it's really easy to get in contact with the team in order to kind of understand the direction for that specific patient. One last point before I end. So the report by SAMHSA outlined strategies to address opioid use in OUD in Black communities that I wanted to share, because I do want to acknowledge that initiating people on medications for OUD is only successful when we refer to social support services and broaden our scope of support to community-informed strategies. So these strategies, alongside behavioral interventions, target a broad range of concerns, not necessarily addressed by medication. So one quote I'll leave you with is, the opposite of addiction is not abstinence, it's connection and compassion. So before I end, I'll have Dr. Jennifer Mark come up. Just want to introduce her to anyone who hasn't met her, and especially for the interns. She's an incredible asset to Kings County, a great person to work with, and she's just been really amazing in this process. So, if you want to come up. Yeah, just thank you to everyone for all the support for all of this. It's really been really amazing to have the opportunity to talk today. This is really great. And thank you to everyone who has been so supportive, critical, both supportive and critical of the initiative, because this is new. This is on very new and novel therapies. And so I want to keep getting better, and I want to improve this as much as possible. So I don't just want support all the way. I do want people to be critical, tell me ways that they can improve, and inspiring me to continue educating myself in our department to be more aware and compassionate doctors and individuals in our community. So, yeah, Dr. Mark.
Hey, everyone. Is that okay? Can you hear me okay? I've met many of you. So I'm Jennifer Mark. I'm the medical director for outpatient substance use disorders here at King's. I've been in my position for about 2 years now, a little over. First of all, thanks, Paul. It was a great presentation. I came here, actually I was brought to King's really to increase the use of buprenorphine for our community here in our little corner of Brooklyn. When I first got here, we had 25 patients on buprenorphine, sort of aggregate throughout the hospital, compared to almost 600 patients on methadone. So this was like a wildly sort of, difference from where what I was used to. I was working in Western Mass where the statistics were basically flipped. Almost nobody was on methadone. Most of our patients were on buprenorphine. And, it's taken me a while to figure out why that is. And it's multifactorial, but, a lot of it has to do with, all the social determinants, the history of methadone and buprenorphine, like Paul pointed out. So the journey to get more patients onto buprenorphine, is ongoing. And I just want to also say that I'm also still learning. So it's, not only is it a challenging patient population in that people are really used to methadone, they've been on it themselves, they've known people on it. Many of these patients have had bad experience with buprenorphine in the past, so they've had precipitated withdrawals on the street. We also have the infiltration of fentanyl into the drug supply has made the buprenorphine inductions much more difficult. So we're kind of faced with this sort of triple whammy of difficulties in getting people onto bup. And it's one of the reasons why this microinduction protocol is really important, because it allows somebody to stay basically perfectly comfortable while they're induced onto buprenorphine. Whereas, the other induction strategies are, often met with some, physical discomforts, sort of perpetuating this idea that, buprenorphine makes people sick, buprenorphine doesn't work, I can't get onto buprenorphine. So in any case, I am really excited to be part of this initiative in the ED. I'm very grateful that the ED has been willing to take this on.